program, sir?
Yes.
Okay, sir. Okay. Welcome to the 21st edition of the WA academic activity. WA is WIMS Anesthesia Alumni, and it was the brainchild of Dr. Bala Bhaskar sir as well as Murder sir. And this is the 21st edition that we are into. We conduct it every month. And today we have Dr. Balaji Bhaskar from Aurangabad. He is a consultant physician, consultant anesthesiologist as well as palliative care physician. And he's also director of Ozone Anesthesia Group, Aurangabad. Sir will be speaking on the getting most out of a 2D ecography report for the anesthesiologist. Welcome, Dr. Balaji, sir. Over to you, sir.
Thank you.
Thank you.
I will share my slide.
Yep. All right.
First of all, I'm really thankful to Bala Bhaskar sir, President Dr. Parimala madam, and Dr. Josna for inviting me for this talk. And why I'm presenting this topic? Because nowadays, almost particularly in cities, metro cities, and all patients who are posted for anesthesia, usually in many places there is a protocol of doing echocardiography. Echocardiography done as a routine, as a ritual for pre-anesthesia evaluation, and everybody concentrate on only one thing in echocardiography, that is ejection fraction. But actually, echocardiography gives us so many other information that many a times as an anesthesiologist, we miss or we overlook on them. So I thought, why not to discuss this? This is very important for all anesthesiologists. I'm working in cardiac anesthesia from almost 20 years. And many things that are more relevant in echocardiography that I'm going to discuss in next 20 to 25 minutes. Basically, you know, echo, we just put one probe over the patient's chest and that sound waves goes and sound waves come back on, and whatever structures we are visible that we try to analyze. And usually we get such report of echocardiography. But most of the time our concentration is, even surgeon, even physician, everyone is concentrating on how much is the ejection fraction. And if ejection fraction is normal, we say that patient's echo is, patients have a very minimal risk, but this is not the fact. So my aim is to show you something that is different. It's a sight is what you see with your eyes, but vision is what you see with your mind. This is a FedEx is a courier company. If I ask you where is the arrow in this diagram, you may not be able to find it out immediately. But once I mark it, this is the arrow in this diagram, you may not forget it in your lifetime. Similarly, few things in echo, if you learn to see with your mind, we rarely forget it. So the aim of presentation is to comprehend the complete, how to comprehend the complete echo report. Then as we may not be, we do not want to be have expertise like cardiologists, but we should able to identify what are the red flags or what are the severe things that are mentioned in the echo. And as an anesthesiologist, I want to correlate for two things. One is to quantify the risk, and secondly, to manage the patient during perioperative period. What is the relevance of these findings? And many times there are something is mentioned which we should not give much attention, and which are those things that I'm going to discuss in my talk. Echo can be done by two ways. Most common is transthoracic echo, that we commonly, it's a very simple rapid test. Expertise machine is definitely needed, but it has got some disadvantage that it has got a lesser resolution, or when patient is obese or thick chest wall, emphysematous patients, then image quality may not be as good as we expect. Another is transesophageal echo that we cardiac anesthetists are routinely doing, but it requires some or the other kind of sedation, or it can be done under general anesthesia, and it requires machine. That probe is also very expensive. So what are the limitations of normal echocardiography? Echocardiography, we all think that once echo is normal, everything is normal, but this is not the case. On the contrary, echocardiography has got many limitations. How the windows are taken, how the patient's position was, how relaxedly that echocardiographer has done this test, whether patient was on mechanical ventilation, whether he properly find out the various measurements. All these, if not done properly, it can give us a lot of erroneous results. Echocardiography, what it conceals. Let me give you an example of recently we have got one patient who has got a classical history of angina. When echo was done, his ejection fraction was normal, but there was a patient was giving history of dyspnea on exertion or angina equivalent. When he's subjected for coronary angiography, you see there is a major block in the left main artery. So even if the echo is normal, this can be present. So dynamic heart condition, echo may not reveal to you, or severity of ischemic heart disease, or dynamic heart obstruction, or gradient of valvular stenosis. So echo, though it is simultaneously revealing so many things, but it also concealing so many things that one must remember. Now, this is typical information that any echo gives us. It talks about left ventricular dimensions, how is the ejection fraction, presence of regional wall motion abnormality, chamber sizes and thickness, similarly in right and left side. Apart from that, if there are valvular pathologies, it can define the degree of stenosis, regurgitation. Then as far as aorta is concerned, it can tell you about dilatation, dissection. It can tell us about pulmonary artery pressure and other findings. And now the most common thing that we look into the echo is a ejection fraction. Ejection fraction is nothing but the how much amount of blood that heart is able to pump with each with its contraction that we try to quantify. When it is below 55%, we call it reduced. And how it is calculated? It is calculated by 2 or 3 methods. First is the whenever cardiologist or echocardiographer put the probe, by just eyeballing, he can say this is a normal ejection fraction or it is a reduced ejection fraction. Secondly, by M mode. M mode, he put his cursor on the heart and he tried to measure this, means LV size, how much is the during diastole and systole, and with simple formula that machine gives us the ejection fraction. Or third is by taking such a kind of views where it actually calculates the end diastolic volume versus end systolic volume. It gives us the information that so and so is the ejection fraction of the heart. But what are the EF calculations limitations on echo? First of all, many times if cardiologist or echocardiographer is in hurry, he may miss ejection fraction data maybe by 5 or 10%. Secondly, if his plane, he is putting M mode cursor in a heart in one of the echocardiography that we call as a long axis view. And suppose he put his cursor and that is a normal segment of the heart. And just beside that, there is an abnormal segment. So this calculation may not be correct. So this limitation, it is a very big limitation as far as echocardiography is concerned. It may not have a variation, means it is like poor LV will not be tolerated as normal LV, but all this in between or middle figures are there that may be erroneous. This method by when EF is calculated by these methods. Another most important aspect as an anesthesiologist or as a perioperative physician, we must know is the diastolic dysfunction. Previously, it was thought that whenever patient is in failure, we used to call it as a systolic heart failure. But now it has been proven beyond the fact that many a times patient can have a heart failure with normal preserved systolic function, what we call it as a diastolic heart failure. And this diastolic heart failure, where heart is unable to relax normally, what it will leads to? It will leads to a back fluid or back increase in the back pressure in the left atrium, which subsequently leads to a pulmonary congestion or signs and symptoms of failure. I have seen so many times that patient has got a normal EF, but that patient's landed in a pulmonary edema in perioperative period. When you review his echo or when you again do his echo, we used to find that the patient is suffering from diastolic dysfunction. So presence of diastolic dysfunction, if at all it is mentioned on the echo, one must try to quantify whether it is a type 1 diastolic dysfunction or type 3 diastolic. Type 3 diastolic dysfunction patients are really very challenging during perioperative period. I always say type 3 diastolic dysfunction patients are like a aortic stenosis patient. They are very difficult to manage in perioperative period for non-cardiac surgery or even for a cardiac surgery. I will not go in details because it will be too technical to talk how to evaluate, how to grade the diastolic dysfunction. But let me tell you, it is first stage is impaired relaxation, second is pseudo-normalization, and third is a restrictive heart filling, or what we call it as a diastolic heart failure. It is usually mentioned in an echocardiography report, the degree of diastolic heart failure. What happens, suppose patient has got an early diastolic dysfunction. Patient will have, all these patients will have a diastolic dysfunction. Like if there is a pressure overload or hypertrophic heart, there is ischemia, previous infarction. So in early stages, patient can have a normal but when subjected for exercise, he may have a breathlessness. When there is a diastolic dysfunction, his patient will have a reduced exercise tolerance. In severe or almost diastolic heart failure, patient have a signs and symptoms of congestive heart failure. So we have to correlate when suppose patient has on echo, it has been given grade 3 diastolic dysfunction. We have to clinically see whether this patient is really is in failure, how is his effort tolerance. So this must be evaluated, and we can optimize these patients by simple diuretics or controlling his heart rate, and which may prove to be very important during perioperative period. Another important comment that echo makes about the chamber. This is a left ventricle, this is right ventricle. How is the chamber, whether it is dilated, whether it is a hypertrophy? Let me tell you, whenever there is hypertrophied chamber present on echocardiography, you take it to the granted that invariably it is associated with a diastolic dysfunction. It may be vary with a severity, but invariably there will be some element of diastolic dysfunction whenever there will be a chamber hypertrophy. Now, regional wall motion abnormality. What is, as an anesthesiologist, what is the clinical implications of presence of regional wall motion abnormality? Let me tell you, many times on echo it is mentioned that anterior wall is hypokinetic, anterior wall is akinetic, or dyskinetic anterior wall. Dyskinetic means instead of it is getting contracted, on a contraction, it is bulging out. This is a much more severe condition, and this can have a LV aneurysm also. So as an anesthesiologist, why I should know this? Because suppose there is a hypokinesia of anterior wall or left ventricular wall. So these patients are likely to go in a failure in a perioperative period. We have to restrict fluid to these patients in perioperative. On the contrary, suppose there is a hypokinesia of right ventricular inferior wall. We may not be able, we may not need to restrict fluid on these patients to that extent when there is a hypokinesia on inferior side of the heart. This is the, as an anesthesiologist, these are the clinical implications when you see regional wall motion abnormality on echocardiogram. Now, which coronary is blocked? This also you can predict with a which regional wall motion abnormality is present. Usually, when there is anteroseptal hypokinesia, akinesia is present, left anterior descending, which is the main artery which is supplying to the left ventricle, is usually have a problem or block, and this is a very dangerous condition, or it is a very high risk patients whenever such patients comes for a anesthesia in perioperative period. On the contrary, suppose this right coronary is blocked, which is supplying the inferior wall and to the septum of the left ventricle. If there is a hypokinesia to these patients, there are high chances of more of a arrhythmia, more chances of right ventricular failure will be there when these patients are come for anesthesia. So which vessel, which wall of the heart is hypokinetic, which is mentioned in the echo. Accordingly, if we face a problem, or we can optimize our patient during the perioperative period. Now, many times this echo is mentioned that there is a dilated cardiomyopathy. Now, what it signifies? It signifies there is a reduced ejection fraction. This patient can have a systolic heart failure, and this patient is very likely to go in a heart failure when you give excess fluid to these patients. There is sudden tachycardia. Those patients landed in pulmonary edema. So we heard whenever such findings is there, dilated cardiomyopathy, reduced ejection fraction, we have to we must proactively manage such patient during the perioperative period. In valvular stenosis, many times we just see how is whether it is mild, moderate, or severe. But beyond that, I request all of you to concentrate on how is the pressure gradient across the wall. This is in all echocardiography report it is written. Means suppose there is a aortic stenosis mentioned. How much is the pressure gradient? What is this pressure gradient? It is a difference between the LV systolic pressure of that of aortic pressure. Suppose when in severe aortic stenosis, it is usually more than 40. It may go to 80, 100. Suppose there is a one patient who has got the blood pressure of 140 by 80, and in his echo report is showing a severe aortic stenosis with pressure gradient of 80. Means his LV pressure is 140 plus 80. Means his LV pressure is 220. His LV is contracting with a pressure of 220. And when such a patient suddenly goes in a hypotension, it can create a lot of problem. So this one must concentrate, or one must always look for the presence of this, quantifying this pressure gradient when he see the echo. Same things with the mitral stenosis also. In mitral, it is pressure gradient is lesser because of this chamber. It is lies between the left atrium and left ventricle, where pressure gradient is less, but anything more than 10 millimeters of Hg will be a severe kind of mitral stenosis. We usually see the wall area in mitral. This is okay. If it is less than 1 centimeter scale, we call it as a mitral wall. So we always look for this important data in echocardiography. Another important case in mitral wall diseases is always look for pulmonary artery systolic pressure. And it is usually mentioned on echo how much is the pulmonary artery pressure. Because if patient has got a severe PH, his perioperative management, his outcome, his risk, everything changes. So always look for this finding whenever you are evaluating a echocardiography report. Now, wall regurgitation. Wall regurgitation, it is said mild, moderate, or severe. How we calculate it? We calculate it by 2-3 methods. One is regurgitant volume, or regurgitant jet, or regurgitant fraction. How much this jet is going? Is it going up to the LA apex? Is it going up to the halfway mark? This is one method. Another method is we calculate the vena contracta. Vena contracta is nothing but it is the width at the level of this jet. More the width, more will be the regurgitation. Similarly, if you can find on echocardiography of vena contracta of more than 7, it itself indicates that it is a severe kind of valvular regurgitation. So rather than just finding the conclusion, means whether it is severe, moderate, or mild, if you try to analyze these things, it is always better in estimating the risk as well as managing the patient during the perioperative period. Now, in particularly one thing which I wanted to mention about the false EF calculation in regurgitant patient. Many times you see on echo report that ejection fraction is around 40% with moderate MR. This is a very simple report it looks, but actually these are the very dangerous patient. Why? Because in the presence of regurgitation, ejection fraction calculations are overestimated. Why this is happening? Ejection fraction is nothing but the end diastolic volume minus end systolic volume divided by end diastolic volume. During this contraction, heart has got now two leakage. One is into aorta and other is in LA. So at the end of systole, there will be less volume. And similarly, at the end of diastole, there will be due to this from this wall, there will be more volume is coming back to the LV. So end diastolic volume is also increasing and systolic volume is also decreasing. So numerator is increasing, which is overestimating the ejection fraction in a regurgitant patient. So suppose patient has got a depressed left ventricle ejection fraction in the presence of regurgitant lesion. These are the most dangerous patient to manage in a perioperative period, and one must give adequate attention to them. Another, I will not go in details of this, but many times this about if there is a prosthetic wall, it is mentioned how is the wall functioning, both leaflets are functioning or not, is there presence of vegetations, and if at all it is there, in risk proportionately increases. We already talked about dilated cardiomyopathy or hypertrophic cardiomyopathy, but the one cardiomyopathy which I wanted to mention special, that is hypertrophic obstructive cardiomyopathy. Here what is happening, that septum rather than whole chamber, septum is abnormally getting hypertrophic, and this septum, due to this lengthening of mitral, one of the mitral leaflet, at the time of systole, it is obstructing the LV outlet, LVOT, left ventricular outlet tract, and which is causing a dynamic obstructive condition. And as rate increases, as stress increases, or if you start inotropes, these patients ultimately can have a decreased ejection from the heart, and so, sudden deaths are very common in patients of hypertrophic obstructive cardiomyopathy. Suppose whenever there is this is mentioned HOCM on his echo, you always must see how much is the dynamic gradient, if at all it is present across the mitral leaflet. Now we see so many pediatric patients with congenital heart diseases, and it's really very difficult to even memorize which type of heart disease is, how, what will be its implication. But commonly we get ASD, VSD, PDA, and it is shown in the echo. But the important point which I wanted to tell you is how to identify the severity of congenital heart disease. Let me tell you, whenever there is right to left shunt, instead of left to right, usually these are the severe congenital heart disease. They are very high risk for non-cardiac surgery. Why? Because from right to left shunt, it means there is a mixing of venous blood with the left-sided blood, and this is occurring usually due to increased pulmonary hypertension or some pathology which is not allowing blood to go in the lung, rather than it is directly shunted to the left side of the heart. More the larger defect, usually severe, will be the congenital heart disease. Any presence of moderate to severe pulmonary hypertension, it is always a severe congenital heart disease. More one or two lesions, complex congenital lesions presence, it is always a severe congenital heart disease. So whenever these are the red flags, whenever you see such report on echocardiography, take it for granted that patient is going to be a very severe, very high risk patient, and it requires special kind of perioperative management, perioperative anesthesia management. Apart from that, we get so many important data during echocardiography. It may be a mention in a very small letter or at one corner of the echocardiography report, but one must know the presence of pericardial effusion or presence of blood clot, presence of infective endocarditis, cardiac tumors, or many times echo usually mentions there is a volume overload or a pressure overload. Suppose heart is volume overloaded, clearly it indicates that during perioperative period, we have to decrease the volume. If it is pressure overloaded, it always indicates that there are pressure changes during perioperative period may be dangerous. So one must give attention. Now on echocardiography, just on echocardiography, how we can assess or how we can say that these are the severe heart diseases on echocardiography. Any ejection fraction below 35% or 40%, usually patient can have a severe kind of heart disease. Any grade 2 or 3 diastolic dysfunction, we have to be careful. High gradients across the wall, again, this can be a severe heart disease. Aortic stenosis with depressed left ventricular function. Because heart is overcontractile during aortic stenosis, but LV function is decreased in the presence of aortic stenosis. These are the high-risk patients. Severe regurgitation with depressed left ventricular function. These are the severe heart disease patients. Any presence of severe pulmonary hypertension, always very high-risk patients. Presence of pericardial effusion, pulmonary embolism, all these are the severe heart disease as per the echocardiography. So take-home message is always see the report in detail. Don't concentrate only on ejection fraction. Echo fraction report must be seen in the context of patient clinical status. Let me tell you, this is very, very important. Many times echo is normal. We try to avoid even auscultation. We or don't take detailed history of the patient. But echo, always remember that echo conceals so many things. So just don't always go with echo report. Everyone says echo is normal. It doesn't indicate, it doesn't certify that patients, everything is normal. This is very, very important. Another is reassess the patient in the context of echo. What does this mean? Suppose I have seen the patients, I have asked history, patients say everything is all right, nothing is normal. But patient, it has been written grade 2 or grade 3 diastolic dysfunction. Always look for signs of failure. How is his baseline saturation? Whether he has got a chest congestion, edema of feet. Because even though systolic is normal, but presence of diastolic dysfunction, you have to reassess the patient. So take-home message is very simple. Always see the echo report in the context of the patient, and echo report itself do not certify that everything is normal if echo report is normal. I am very thankful for you to invite me to talk on this. And I do request you to come to Aurangabad to visit these historical monuments which are present nearby in Aurangabad. Thank you very much.
Kiran? It's very nice and somewhat to the point presentation. So I think the PGs and the practitioners today would be benefited a lot. But in fact, we have this live on the YouTube also, and this is available for people to view later on also. So thank you very much, Dr. Balaji, for a nice presentation. So let us see if we have some queries from the group.
Yes.
In fact, one of the things is people are now overexposed to echo reports. So to the extent that it has become a routine one, probably people will not ask for hemoglobin, but will ask for echocardiogram.
Yes.
So despite the strict limitations or indications are by the AHA's guidelines also.
Yes.
So the limitation.
And unfortunately, if echo is normal, everything considered this patient is to be normal. Whatever, nobody is looking at on clinical status of the patient. Even surgeon is saying, echo is already done, it is normal. There is no risk. And unfortunately, these things are very common nowadays.
So, of course, in the pre-anesthetic evaluation, we are supposed to more clearly assess the functional limitation or the functional capacity of the patient. That's the first, most important thing. So
Yes,
that would be the basis for advising. For example, the AHA guideline will mainly advise about this major important consideration. So, somebody doesn't have any functional limitation, is otherwise active, and trying to ask for an echo, generally, there is no real indication, I suppose.
Absolutely, sir. As per ASA guideline, suppose patient is doing MET 10 or 9, he can swim, he can play. There is no need of any cardiac, evaluation. That is what clearly mentioned in that.
So before we go to the questions from others, just a continuation of trying to understand the echo report would be trying to do an echo ourselves on the table sometimes. So, of course, it is not part of today's discussion, but can you please inform us about the utility of the on-table echo in cardiac patients for non-cardiac procedures?
Yes, sir. In my practice, we have got a cardiac theater on the same floor, and 2 or 3 theaters are just beside that. And invariably, whenever there is a problem or patient becomes hemodynamically unstable, first thing what we usually do is we put a echo probe and see what are the findings. And so many times we find something which really changes our management line of management. So I think, and nowadays so many workshops are going on. One can, if somebody decides, he can learn this focus, this point of care echocardiography, or he can very well master this basic echocardiography training.
Yeah. So in fact, Dr. Umesh has put a message and question in the chat box. Dr. Umesh, you are online, free to put the question directly. Dr. Umesh? Okay, I can just read out. So what Dr. Umesh has written is, of course, it's interesting talk, simplified enough for those even with less knowledge of echo to start looking for warning signs. Just as part of preoperative investigations, who asks for echo? Is it the anesthesiologist based on history findings, on clinical evaluation per se, or refer to the cardiologist and cardiologist uses a discretion to ask for echo? If echo that is number one, I think that's the first question. That is whether based on our physical evaluation and history taking, whether we decide to ask for an echo, or we don't ask for echo, but straight away send it to a cardiologist and let the cardiologist decide whether to do an echo or not. That is the first question he has asked. Second question he is asking is, if echo is done earlier and it was normal and patient is stable, and if the patient is going for surgery, can previous echo report be accepted? And if yes, how much gap is acceptable? And any guidelines?
Yes. So based on, suppose there is a clear-cut cardiac symptoms, or you feel that patient has got some cardiac problem, I think it is better to refer patient to a cardiologist, and invariably he will do the echo for such patients. And it is better to take his opinion. Another, in case of emergency, if cardiologist is not available and if cardiac anesthetist is there, in many times in emergency cases, we also do the echo of such patients. Second question that has been asked, whether how much duration echo is acceptable. If in our hospital, we have a policy to accept up to 6 months, provided in between patient don't have any episode of angina or heart failure. If this criteria and patient is moving around, we don't have any complaint of heart, and echo is of last 6 months, then we usually accept it without any there is no need to repeat the echo in such cases.
Okay. Umesh, your audio is ready? Dr. Umesh? Okay, unmuting did not help. So what he's also typed in the chat box is, today itself I had a patient with normal echo report done in early 2021. But after intubation, when auscultating for breath sounds, realized that the patient had pansystolic murmur, loud murmur, which was loudest at the mitral area. Can this be possible? Was something missed during the echo, or something could have developed recently, though the patient's history was stable during the intervening period? Can flow murmurs not be detected on echo?
Yeah, flow murmur will not be detected on echo unless there is a regurgitation produced, means anatomical disturbance in flow. Then only it will be detected on echocardiography. Firstly, and secondly, this even our pre-op evaluation. Suppose you auscultate patient and you find a pansystolic loud murmur, and unfortunately it is not mentioned in the echo. Then you have got our basic investigation like ECG, X-ray. These are also very important. Suppose there is no cardiomegaly, or in this patient there is a presence of cardiomegaly. Naturally, it will indicate that in presence of systolic murmur with cardiomegaly, this can be a cardiac condition. Or X-ray on ECG, there is a LVH, left ventricular hypertrophy, or left atrium is enlarged. All these you have to correlate. Echo, as I have mentioned in my presentation, echo is one of the tests, but you have to see the patient. You have to see the other parameters. I also much more rely on our normal 12-lead ECG. It also gives a lot of information. X-ray, normal X-ray also gives us a lot of information.
Yeah. So because Dr. Umesh was the lead coordinator for our ISA preoperative investigation guidelines.
Okay.
So very much work was also checked about the role of X-ray, ECG, and the 2D echo also in the preoperative period, whether they would be part of discussion about pre-op investigations. And the validity time for preoperative ECG and the X-ray was also considered. I think about 12 months was considered as a period where we could still accept the previous report, provided there was no deterioration or change in the condition of the patient.
Yes.
So that was the one thing that was put as a rider. But now that you say in your institution about 6 months generally is okay, as long as the patient's condition has not changed. Could be related to ischemia or any other thing. So if there is 6 months old echo report, we can very well accept it, provided we fulfill our expected responsibility of doing a thorough pre-anesthetic evaluation. So we should be doing a thorough pre-anesthetic history taking and examination, and of course keeping in mind the AHA ACC guidelines.
Yes.
So if we follow the guidelines, I don't think we'll be on the wrong side of the law also.
Yes.
So because now he mentioned about finding a murmur. If everything went on well and surgery was over without complication, if the patient lands into problem,
Yes.
so if we have not done a new echo after 2021, and because of development of a new form, probably an organic heart disease, so that will be the risk for all of us.
Yes.
Yeah. So then we have got one more question from. It's a common question. Dr. Krishna Sagar is asking about effort tolerance and the echo report.
Effort.
Yeah.
Yes, whenever patient has got a decreased effort tolerance, one must look for, naturally everyone look at the systolic function, but the presence of diastolic dysfunction. Many times cardiologists don't mention the degree of diastolic dysfunction on echocardiography. But we in our institute requested cardiography, just don't give, just don't mention only diastolic dysfunction. Always grade it, whether it is a grade 1, grade 2 or grade 3. And invariably, the patient, even though he has got a normal systolic function, but his effort tolerance is less, he is a hypertensive, obese patient, and he feels even breathless after climbing one flight of staircase. It is usually presence of diastolic dysfunction. And definitely diastolic dysfunction decreases the effort tolerance.
Yeah, it's possible. And there is one question. it's directly not related to today's presentation because we were discussing mainly about the how to read an echo, basically, echo report. So here there is a question, maybe you can decide to take it. Role of echo-guided shock management and goal-directed fluid therapy.
Yes, this is coming in a very big way. And particularly if you are well versed with doing echo, and particularly if you are managing a shock patient where you don't know the reason, and you just put a probe, echo probe, and you find that heart is contracting normally, or if it is hypercontractile, or if walls are just like kissing each other, means there is a hypovolemia. Immediately, as soon as you keep the echo probe on the chest, either you can rule out cardiac cause. If you rule out the cardiac cause, you can confidently treat these patients in a better way. Or if at all you find out the cardiac cause, you can direct your management accordingly. So I think nowadays, maybe in future, this all shock patient will be by echo-guided shock management is going to be there in very near future. And every anesthesiologist, maybe today or tomorrow, has to learn echocardiography. There is no option. What is I think, or whoever is working in critical care area, he must be well versed with at least basic echocardiography.
Yeah, it is perfectly true because we are looking at the cardiac chambers and the contractility. Number two, the vena cava features also with respect to the fluid status of the patient. So, as you say, probably not more than 5 years. 5th year from now, everybody will have an echo in the OT itself. And we can do it many times in the preoperative area itself. That's a possibility. And Dr. Umesh has put a question. Is a contrast echo, what is the utility of contrast echo and when is it necessary?
Yes, sir. Echo, contrast echo we do usually when we are don't know about shunt, whether it is a left to right or right to left. What usually we do, we take maybe suppose air contrast we are taking, we take some half-filled air syringe, we agitate the syringe and we keep an echo probe on the chest and we suddenly inject that agitated fluid into the heart. And we see the course of that fluid into the heart. Suppose there is a VSD, and VSD naturally, first it will go to right side, and if without going to lung, it is crossing across this VSD, this contrast, it indicates that there is a presence of right to left shunt. For this confirmation type, we usually do contrast echo. Nowadays, people are not doing this because we have got a color Doppler. We can easily find out how is the by Doppler whether it is right to left or left to right shunt. But in rarely, again, suppose there is a PFO or very small ASD which is not easily visible even with echocardiography, then we use contrast echocardiography. Suddenly you find this air contrast on the chambers, and you can see the presence of this smaller ASD, or that contrast echo is used.
Yeah. So there is a possible, I mean, definitely using an agitated air is the simplest one, which can be done in the bedside.
Yes,
That itself would be like a contrast for the management. And this is a common question. Common practical possibility. Dr. Srinivas is asking about certain cases. For example, we do regularly orthopedic cases everywhere. So especially the patients are just elderly. So in the absence of comorbidities or in the absence of significant comorbidities, is it justified to get an echo done for the patient in a high-risk non-cardiac surgery?
Yes, in ortho cases, particularly in geriatric population, where you cannot assess his functional status, and patient has got more than 2 comorbidities, and patient is bedridden maybe for more than 1 year, he has got a severe osteoarthritis of the knee, we cannot assess his even basic functional status. I think in that case, it is better to have echocardiography in these patients.
Okay, so we have one of the participants raise a hand. So you can speak out, please. Because I don't have the name. They put the name of the hospital. You can speak yourself. It's no problem.
Somebody has asked, please enlighten more of transesophageal echocardiography, learning curve, and
Yes,
early detection of interoperability of MAIA and VAE. So
Yeah.
I will tell you, there is definitely a learning curve for transesophageal echocardiography, right from putting transesophageal probe itself, because we are not used to putting transesophageal probe. It's a bit bigger than our Riles tube, or it is more like of 8 or 8 French endotracheal tube, and you have to practice it, and then only you will be able to do. But it's a very simple investigation, and the important factor or important things that it shows the clarity of image. Means once you put it, particularly under general anesthesia, it is of immense help, and particularly in neurosurgeries, we have, apart from cardiac surgery, we have used it for posterior fossa surgery, where we can detect the air embolism, and we could successfully detect it so many times. So if it is available, only inhibitory factor is cost. The probe is very costly, and you require a dedicated machine. Hospital should ready to keep this machine during in operation theater complex. These are the definitely inhibitory factor. But if it is available, and if you learn it, it is very big, I think, monitoring tool in armamentarium of any anesthesiologist.
Okay. And sometimes again, we have reports where the cardiologist would have written that there is a poor echo window. The patient is obese or on ventilation. So how much of the report can be accepted on face value?
Yes, that's a very good question. Let me tell you, sir, even if he has written a poor window, but at least he will comment about the chambers, or at least ejection fraction. Means he either by eyeball method, or maybe by one or two way, he will at least he comment about the presence of ejection fraction. But all other smaller or finer details of echo may not you may not get when there is a you don't get a echo window for echocardiographer. In that case, I think dynamic conditions we may not be able to assess, but we must, for that matter, we must should not leave the habit of looking at ECG, looking of basic chest X-ray and history taking, even our blood pressure, our heart rate. These are very important parameters. Even baseline saturation. Suppose one patient has got a 95 saturation and other has got a 99. Baseline decreased saturation, it itself is a very big clue for us to evaluate this patient further.
Okay. Another around three questions are there. Gurdas sir, questions, sir?
No. I just want to congratulate Dr. Balaji for an excellent talk on echo, because most of our students, when they even tell us about the pre-anesthetic evaluation of the patient they have done, so they only concentrate on the ejection fraction. They say that ejection fraction is this much and that much. They don't concentrate on many of the parameters that are there in the echo. Now, Dr. Balaji in his talk has made it very clear that what are all the things which has to be given a lot of importance. As Dr. Bala Bhaskar, you were talking about on-table echo. That is, I think, maybe very, very important later on nowadays, because the learning echocardiography is becoming very important for all the anesthesiologists as well. Like, you can detect many times on table many of the abnormalities which had been probably had taken place during the perioperative period. Like recently, what we had, a neurosurgery, spine surgery was going on. Suddenly, the patient had severe hypotension. Fortunately, the surgery had just ended, so we had to immediately turn him on and then placed a echo probe on his chest. There was a thrombus in this right heart. He has developed a pulmonary thromboembolism. So that was the reason for his hypotension. So that like if you have a sound knowledge of about even doing an echo, and not like probably a cardiologist, at least few of the important things. You can use it even point of care echo like on table also. So thank you, Dr. Balaji, for the nice presentation. And one more thing, I just wanted to ask regarding transvalvular gradient. You were mentioning just about 40, 30 or like that, but many times I am seeing two measurements will be there, like 30/10 regarding pulmonary arterial pressures, or even for the transvalvular gradient across the aortic valve, also 80/30. Like why, what are these two things? Is it a mean gradient on one side or a systolic pressure gradient? What are these things?
Usually,
times
sir,
with the equal
in case of pulmonary artery, the pulmonary artery pressure they mention means 30/10, means systolic by diastolic pulmonary artery pressure. And let me tell you, for pulmonary artery pressure, diastolic pressure is very, very important, even more than a systolic pressure. Because on increased pulmonary diastolic pressure, it is a very detrimental sign for cardiac people. So usually this diastolic phase is usually mentioned on echocardiogram. Another important question somebody has asked on this: how PCP&AT Act, especially for anesthesiologists. Let me tell you, sir, we have done this TE courses and echocardiography courses, and that certificate we have produced in our corporation, sent through our hospitals, and they have recognized us as echocardiography, allowed us to handle these probes. We have given in written that we will not handle the abdominal sonography probe, which usually PCP&AT people they are strict about, but we will only handle the cardiac probe or transesophageal echocardiography probe. And they have given a license to us to use this probe in Aurangabad.
That's what I saw that message. I thought I will keep it to the end because it's many of our practitioners would want to know. Dr. Mohan rightly has asked it. In fact, one of my colleagues from neighboring government medical college called me about a week ago that the local ethics committee said you cannot use an ultrasound in anesthesia department. So that's what was a question. So he was asking me how and all. So number one, as you say, I also told him the same thing. So when you talk about the postgraduate and the current competency-based medical education system from the National Medical Council and the respective state universities clearly states that in the first year and second year and third year and all, what all you do, the PG should do, including about the use of ultrasound and echo. So that they should be learning to observe, then get trained, and then do independently also some procedures. It could be regional anesthesia or invasive putting IV lines, or it is also related to the airway and the blocks. So that has been clearly mentioned. So that I have told that to the level of the postgraduates, normally we should try to convince the ethics committee members, number one. So, and there is no need for them to reject it. But secondly, the more important one, which Dr. Mohan is raised, is about the private practice and the use of ultrasound. And you are lucky that the corporation authorities have recognized your expertise after doing the specialty post-graduation. But as Dr. Mohan has said, in many of the institutions, especially the district hospitals, so it is not normally a problem in medical colleges. It's the district hospital levels in the health department where there is a question because the PCP&AT is considered very seriously there. So as you said, number one, if we say that we are never going to talk about the sex determination, the problem is about sex determination as per the PCP&AT Act. So that is one thing. And number two, again, we have to suggest about the CBME requirement to learn and understand, and we are empowered to practice, including in the ICU. So this is the one which you have to try to convince them. Problem is at the level of the district hospitals where there is an authority, normally the DHO, who is authorized to license the nursing homes. So they would want only a radiologist or a certified obstetrician, and of course a cardiologist and a physician who can handle the ultrasound or echo that way. So my take on this is he is talking about ISA. So in the ISA also representations have gone. But ultimately, what information we have got is we are not going to get an explicit government circular telling that anesthesiologists will be empowered to use. It's not so. So they are straight away telling if you are studying an ultrasound with ultrasound and if you are going to use it as per the NMC guidelines, nobody is going to question you. So clearly we will not get a certificate. When cardiologists are doing, cardiologist, once he passes the DM, he is not going to get a different certificates that you are qualified to do an echo. So similar is the situation with anesthesiologists also. So government will not we cannot wait for the government and government will never respond. Multiple representations have gone from ISA, National ISA also. So this is the final meaning of what the government is telling. So we can very well go ahead with the practice. And if you want to talk in terms of some convenience, in a hospital, we can always enlist the support of a local radiologist. So you can say that radiologist can lend his name and we can do the procedure. And even in terms of the post-graduation, in some institutions, some of our colleagues in the ethics committee are very adamant. So one bypass system that has been followed in some of the institutions is you say that radiologist is involved in the study. So request a radiologist in the same hospital. Tell that initially I will do some cases with the help of the radiologist. It will be like a pilot study. Then I will get used to understanding and I will be able to operate and go ahead with the study and convince the ethics committee. The ethics committee doesn't get convinced. You can say in all the cases a radiologist was present and the study is completed. But of course, that's left to some mutual adjustment with the Department of Radiology. But otherwise, we don't have further answer to this, unfortunately, to Dr. Mohan. Dr. Mohan, you are online, you can speak also. You are there? Okay, so Dr. Vidya, this I think you have already answered, Dr. Assessment of period of MI. How early we'll be able to detect the changes in echo. And, yeah.
Yeah, rather MI, we can during cardiac cases, we are putting echocardiography probe, or suddenly suppose patient becomes hemodynamically unstable, even though we have not put it previously, we will again reinsert the probe. And many times we found it that as early as just starting of hypokinesia of one valve, which was not there previously, and suddenly hypokinesia developed. It may be the start of MI, and you can very well comment that there is ongoing ischemia has been started. So you can immediately, I think, pick up this finding on echocardiogram.
Yeah.
Especially particularly on transesophageal echocardiogram.
Yeah. Transesophageal, you'll get the best images.
Yes.
But as you say, it requires training and it's a costly device also. And yes, the wall motion abnormalities are the earliest indicators. That's the one. Then I think Dr. Vivek has asked for any short-term courses for focus echo for anesthesiologists, given the learning curve.
Yes, there is no other option. You have to multiple times do this course, do practice, again go for these courses. I must myself learn from Narayan Rudale, Bangalore, and started practicing on our patients. And slowly, but still I have to learn so many things. But this is how you have to go. And nowadays, due to this YouTube and all these continuous online courses, there is ample. Suppose anything you want to decide to learn, I think there is any inhibition for that. On the contrary, so much of material and possibilities are available. You can very easily learn all these things.
Yeah, that is true. That is true. Luckily, majority of our programs, scientific programs, have got a workshop of focus, point of care ultrasound for everything, including the echo and including the regional anesthesia and the airway nowadays. So I think all of us should attend it. Number one. Number two, understand the first time. Second time, you can understand better. And third time, you can start implementing. There is no way. It is one of the easiest things to do. And YouTube has got multiple videos which are self-explanatory and very much helpful. So not difficult for us to become at least an average echocardiologist per se. Gurudar sir, anything else, sir?
So regarding this eco courses and all, like recently when we had this COVID pandemic, even our cardiologists wanted all the anesthesiology postgraduates to learn about eco from them. They wanted to conduct about 3-4 days courses, like just short term, 3-4 days, so that they'll not be called in the ICU repeatedly. So that the anesthesia PGs themselves can do the transthoracic echo and find out any problem, major problem if it is there. So that's, many of the cardiologists are eager to teach us. So that can be, we should take that benefit and then learn things.
Okay. So I think there are no more questions. It has been comprehensive enough within a limited duration. Of course, this is available in the YouTube now, and anything whoever is missed the program in the beginning part, initial part, you can always have a look. I'll share the link also. I got some input from Dr. Umesh again. Umesh. Okay, so he has also talked about a free workshop being conducted during the COVID times with respect to the echocardiograph short workshops. Okay, thank you. Thank you very much, Dr. Balaji. Dr. Kiran, can you please take it forward? Kiran? Kiran is online. Okay, so thank you very much again. Unfortunately, our secretary of the local branch got a little bit busy today and could not actively participate. So on behalf of the ISA Ballari branch and the WIMS Alumni Association, I thank Dr. Balaji for he is a cardiac anesthesiologist himself, very active, both academically in practice and in our association activities across the country. Thanks for spending this time and sharing his knowledge. Thank you once again, and we'll hope to have your participation with some other topic from you in the future.
Yes,
thank
sir.
you.
Thank you very much. I really enjoyed the question, and you are invited me. I really feel privileged. So thank you very much.
Thank you very much.
Thank
Good day to everybody and good night. It's not good night. Good day. All the
Yes.
best for